Two. Oh, thank you. And we have a nice quorum of 25 participants. So I'm going to get started. Welcome everyone to the Center for Addiction Medicine and Policy speaker series. My name is Jean Marie Perrone, and I'm an emergency medicine and addiction medicine clinician and leading the efforts in our health system to get people into better addiction care. So it's my pleasure today to introduce Dr. Andrew Huhn, who's an associate professor of psychiatry at Johns Hopkins and has a very unique position in a, I guess I don't know the exact term, clinical trials research unit, where some initiation of buprenorphine occurs. What I've come to know Dr. Huhn's work is because we've cut and pasted his fentanyl elimination graphs into many papers and talks that we've all given. And I think he was the first to describe the experiences in that unit with people having delayed onset of withdrawal symptoms and the experiences of fentanyl precipitated withdrawal with a good explanation for why it might be occurring. So I'll turn it over to Andrew, and thank you so much for being here. So he asked him to speak for about 30 minutes, and then we'll open it up to questions because this tends to be a very important topic and sparks a lot of conversation. So thanks again.
Yeah, great. Thanks for having me. And thank you everybody for coming. It's nice to see some folks that I know on the call. So, so today we'll be talking about fentanyl and how this has been disruptive for many of us who are in this opioid use disorder treatment space. As Dr. Perrone mentioned, I'm not a clinician. I'm actually a neuroscientist by training, and I work in a behavioral pharmacology research unit where we do a lot of clinical trials in folks with OUD, testing kind of a range of medication approaches to improve treatment. And my interest in this particular topic came because we were doing a trial where we were getting people onto bupe for the purpose of tapering them off of bupe and looking at their sleep. But the hardest part of the study was getting people on bupe in the first place. And that actually kind of dominated our our efforts in that study. Everything was kind of easy if we could get them onto the bupe. So this sparked a lot of initial research by us, and there's some other research has been picking up on this topic. So these are my disclosures. I don't have any financial conflicts of interest. I do receive research funding from NIDA and NHLBI and Ashley Addiction Treatment, which is a nonprofit addiction treatment facility. So these are kind of main objectives today. We're going to look really briefly at national trends in fentanyl use and opioid overdose mortality, talk about the pharmacokinetics of fentanyl, specifically as it relates to opioid use disorder, talk about how fentanyl and its analogs might impact opioid use disorder treatment. And then finally, I hope we can all discuss different approaches that might improve treatment for folks who are using fentanyl regularly. So this is recent data on the rates of drug overdose deaths in the United States. And the majority of these overdose deaths are driven by fentanyl or by opioids in general. And of opioids, the majority are driven by fentanyl. It's a major issue still in the Northeast, Mid-Atlantic area, Midwest. It's increased in the Southwest in recent years. I would still say the kind of epicenter of the epidemic is in this kind of West Virginia, Ohio, Kentucky triangle. But we certainly see our fair share of opioid use disorder in Baltimore. We always have. So it's a big concern for us locally. I know it's a big concern up in Philadelphia as well. So this is an interesting case study from Ohio, where they were looking at the percent of drug seizures that contained fentanyl across the years 2014 to 2021. And in the upper left is methamphetamine that contains fentanyl. And as you can see, in 2014, it was practically none, 0.2%. Now it's up to almost 5%. That would be significant for somebody who uses methamphetamine regularly. You'd have a 1 in 20 chance of getting buying a bag that contains a drug that you maybe weren't expecting. Cocaine is even more. That started at less than 1%, and now it's up to 15%. And this isn't just in Ohio. This is kind of happening all over. Cocaine being primary candidate for fentanyl adulteration. And then, of course, there's heroin. So in 2014, only 3.5% of drug seizures contained fentanyl in Ohio, and now it's 81.5%. So it's almost all heroin in Ohio contains fentanyl. I would say in Baltimore, it is, I don't know, 99.5% of the illicit opioid supply contains fentanyl. I haven't seen somebody test positive for heroin and not fentanyl in a very long time. So just as a brief overview, fentanyl's a highly potent mu opioid receptor agonist. So it's about 100 times more potent than morphine, about 50 times more potent than heroin. It's metabolized primarily by CYP3A4, and it's excreted in urine, which is probably what we are all testing for the presence of fentanyl, both as fentanyl and norfentanyl, and about a 1-to-3 ratio there. So majority being excreted as norfentanyl. The actual duration of effects is fairly short when you're using intravenously. The analgesic effects are about half an hour to an hour. If you do intramuscular, it's about 1 to 2 hours. But the respiratory depressant effects can persist longer than the actual active drug effects, which is one of the first problems I'm going to highlight with fentanyl. So at this actual receptor site, at the mu opioid receptor site, there is a relative bias in signaling. So on one side of the scale, it's biased towards analgesia, and on the other side, it's biased towards respiratory suppression. And fentanyl, while it is a very strong analgesic, it's actually biased towards respiratory suppression. So you have a higher chance of experiencing respiratory suppression from fentanyl relative to another opioid such as morphine. But that's not all. So in the previous, this is biased towards beta-arrestin 2 signaling. And here I'm showing fentanyl at the mu opioid receptor at the cell surface level. And so what beta-arrestin does is it actually induces endocytosis or downregulation of mu opioid receptors. So for somebody chronically using fentanyl, they're actually experiencing even more downregulation of mu opioid receptors, perhaps, than other opioids like heroin or morphine or oxycodone. And this has implications for tolerance and for dependence. So our kind of classical neuroreward pathway would be dopaminergic projections from the ventral tegmental area to the nucleus accumbens, and this is kind of your primary reward signaling. Opioids, of course, induce dopaminergic signaling, but there's opioid receptors right on the nucleus accumbens, so you don't need dopamine to signal reward. You can do it with opioids alone, so it's a dual signal. And as tolerance increases, as dependence increases, there's a downregulation of both dopamine signaling and mu opioid receptor availability, which can cause a kind of further and further dependent state. It makes it more difficult in early recovery as people are struggling with cravings and a kind of lack of response to things that should be naturally rewarding, like food or positive social interactions, sex, a whole host of things that don't feel like enough anymore. The drug kind of takes over and hijacks this neuroreward system. So key points here. So chronic fentanyl use would downregulate mu opioid receptor availability, perhaps more than other opioids. It would also, the beta-arrestin signaling desensitizes mu opioid receptors to other opioids. So morphine is not as effective in people who use chronic fentanyl because those receptors are desensitized. It decreases dopamine signaling in the brain reward system and also increases the risk of respiratory depression. There's even more differences between fentanyl and other opioids. So fentanyl actually crosses the blood-brain barrier more rapidly than other opioids. And in this figure, it's showing a neurovascular unit. In the middle is the capillary lumen, and then the endothelial cells surround the capillary lumen. And basically, fentanyl is actively transported out of the blood and into the brain. It's not very actively transported in the other direction. So there's an imbalance there that pushes fentanyl across the blood-brain barrier at a faster rate. This makes people feel high faster, and it kind of increases the rapidity of the whole experience. There's also evidence that chronic fentanyl might result in biphasic elimination patterns. And this, I'm going to first talk about the metabolism. So we can talk about the parent fentanyl compound, but there's also all of these fentanyl analogs, right? So even on a metabolic level, these different analogs are being metabolized by different enzymes and different pathways. If we look at how some of these different analogs compare to fentanyl, so at the top of this graph is transdermal fentanyl, which is like the fentanyl patch, fentanyl via IV, and then these are some different common fentanyl analogs. And the reason I'm showing this is really to point out the differences in terminal half-life and the relative potency compared to either morphine or to fentanyl itself. So even in the transdermal patch, the half-life changes pretty dramatically from 2 to 4 hours IV to 20 to 27 hours after patch removal. I'm not even sure how accurate this is, because a lot of the studies on the pharmacokinetics of fentanyl, they are collecting data over a pretty short period of time. It's like a day, maybe a few days, and usually not in people who have been using fentanyl chronically over a long period of time. It's mostly like people who are naive and are getting a single dose or maybe a few doses in a single day. But other analogs have very different terminal half-lives, right? Remifentanil is extremely short acting. It's 3 to 10 minute half-life. Sufentanil is around 160 minutes. Carfentanil, which is showing up in the drug supply, is way more potent than just fentanyl. It's 100 times more potent. It's 10,000 times more potent than morphine, and it has a half-life of 5.7 hours, which is a major issue for opioid overdose reversals. And I think a kind of reoccurring theme in this part of the talk is that we just don't know very much about the analogs and how they might impact a whole host of outcomes, not just drug use and overdose outcomes, but also treatment outcomes when you're trying to transition people off of fentanyl. And there's just is a paucity of data out there on the PK of fentanyl in people who use it chronically, people with opioid use disorder. All these studies are looking at fentanyl as an analgesic and not as a drug that's used recreationally. And so there is I think a very large need for more work in that area. There's more evidence that fentanyl has this kind of biphasic clearance pattern. On the left here is a simulation of the cumulative amount of opioid that's cleared over time into the systemic circulation via the spinal cord, which is the dotted lines, versus the epidural space, which is the solid lines. On the right is the transfer rate constants for drug movement into the epidural fat. So morphine doesn't really move into adipocytes, into epidural fat. Fentanyl does at a very high rate. So it's highly lipophilic, and it is being pushed into adipocytes where it can be stored and re-released at a later time. And that's why, likely why we're seeing people with kind of this high variability in how they experience withdrawal when they're actually ready to begin buprenorphine. This, could explain that in part. And it's something that I became very interested in. Again, as I mentioned up front, that we had been doing a study where we were inducting people onto buprenorphine, and we were precipitating withdrawal early on in the study. And it was really frustrating for us. And definitely frustrating for the patient. So we did this pilot study. I was noticing that people were testing positive for fentanyl in that study for longer than they should, and they were in a residential treatment unit. So we moved this out to Ashley Addiction Treatment, which is a 28-day residential program. And we just enrolled a small sample, about 12 individuals, who tested positive for fentanyl. Now, whether they had chronic fentanyl use or not, a few of them did, and they knew they did. Other people didn't know that they had fentanyl in their system at all until they took a drug test. I will say that I think this probably underrepresents what we're seeing in urban areas where, especially somewhere like, well, this isn't in Baltimore City, this is outside in the county. In the city where people are using fentanyl every day constantly, we're seeing even higher levels than what is reported in this study. But the big takeaway here is that the average time to clear fentanyl from the system was 14 days. And that's way different than the 3 or 4 days that's normal for any other opioid. There was a very large range, a lot of variability in the amount of time that fentanyl took to clear. And the length of these lines represents the longest that we observed somebody testing positive. And we did have one person who tested positive all the way through treatment. Very low levels, of course, in the end. I don't know that it's biologically relevant at that point, but it's still there. And we're still seeing relatively high levels in the first, couple of days, even the first 5 days. These are probably clinically relevant levels. But it's not just fentanyl anymore, right? I mean, people are testing positive for fentanyl and all these different fentanyl analogs, and they seem to kind of pop up. I think that they're different and different patterns of analogs being across the country. And we just don't know a lot about how the different analogs might affect treatment. So these are some of the common analogs that are found in the drug supply and that you may or may not be familiar with. I don't know what, I think everybody has their own testing protocols. For my studies now, we're sending in our urines for fully quantitative testing, and they give us semi-quant for several of these analogs. And it's just been interesting to us to see how these pop up or don't pop up in certain individuals. One thing I wanted to show, so this is data from Neil Varshnia, who was a postdoc in the lab, and he did a lot of preclinical work on fentanyl analogs as a graduate student. This chart is showing, it's actually a lot of kind of exotic fentanyl analogs. That was one of the things that he was working on. But here it's showing basically the respiratory depressant effects in the open circle versus how well naloxone reversed those effects in the filled circle. And the point of this isn't that I'm going to go over every fentanyl analog in detail. What I just want to point out is they all look different to me. Like some of them look similar, but there's some big differences here. And so it's like, we just don't know what's going on with these analogs. And this is another chart similar. This is like a basic like drug effect assay. And here we have morphine and fentanyl, and then isobutyrylfentanyl is rather common, and the rest of these are rather uncommon. But even like the drug effects, they just follow different patterns. So as we're seeing these, the fentanyl supply, the opioid supply being adulterated with fentanyl, and then, these different fentanyl analogs, what are the consequences of that? It's like a big open question. But certainly the risk of overdose has increased dramatically during this time period. And this is probably a contributing factor. And it's a bit like, playing whack-a-mole at a carnival. As of the time that I made this slide, maybe 6 months ago or something, there's 9 structural classes of fentanyl. There's over 121 known fentanyl analogs that have appeared in the illicit drug supply somewhere in the world, and that number is growing. So this is a problem that isn't going away. Some of these analogs are very easy to make. You could make them in your kitchen, and I'm sure that's very attractive to people who are selling this product. And it's a major issue, and it's you know, the kind of the future of how we're going to address the opioid crisis, I think, depends in large part on how we address the fentanyl crisis. So thinking more about treatment considerations, I'm going to talk a little bit about fentanyl and drug use behaviors, and then also how the proliferation of fentanyl might affect different types of treatments. So there's been some anecdotal reports, maybe some data that suggests that some people are preferring fentanyl, and I'm sure that some people do. I don't think most people do. And this is a study that we did in 69 people who currently were using opioids, and we asked them hypothetical questions about their drug use. This was like a behavioral economics study, so we framed some of the questions by prompts that were related to drug impurities, and others that were prompted about the risk of opioid overdose in a given batch. And then here I'm just showing what the demographics of the sample looks like. It is skewed towards white individuals, but the rest of it is pretty standard for an OUD population. Most people in the study had a history of opioid overdose. Those people who had overdosed a little over 3 times on average. When they did overdose, the vast majority, heroin was involved, about 44%. They knew that fentanyl was involved, and then kind of other drugs and alcohol are mixed in there as well. So this is the demand for, in this study, you know, and of course, the limitations to all studies, and this is a smaller sample size, et cetera. But this is the opioid demand for heroin versus fentanyl in this sample. So people greatly preferred heroin over fentanyl here. And this kind of matches up to anecdotal reports that when I've talked to patients who are in our clinical trials, they don't like the fact that they have to take fentanyl all the time. And one person described it to me as like, you know, before it was always around, you know, when it was rather rare, then you kind of liked it because it was like this novel thing that you could do, and the high was a little bit better and it was real quick. And you know, but now that they take it all the time, they don't feel that high anymore, that they feel like the dependence is greater and that it's just more problematic. And I think that's probably reflected here in the demand for heroin versus fentanyl. So prompting people about the impurities that might be in their opioid supply didn't actually have an effect on how they might purchase opioids or use opioids. We gave them prompts about like impurities that might be harmless, like baking soda, impurities that might have drug effect or active impurities like fentanyl, and it didn't really change the probability that people would use a certain drug. But talking about risk of opioid overdose, death did. And so this paper, I think we actually titled it like the discounting of death or something like that, some very dramatic title to this paper. But basically, you know, we prompted in this round saying like, you know, 100 people have taken opioids from this batch and nobody overdosed. How likely are you to use it? And then, you know, 1 person overdosed, and then, you know, 5 people, and then 25 people, and then 50 and 75, et cetera. And so the more dangerous that they thought the batch was, the less likely they were to use it. And this was significantly different than the purity discounting. And I think it just helps to think about how we frame talking about opioids to people who are actively using, that when we focus more on the very salient risk of overdose death, that might actually have the greatest impact on their drug use behaviors. We also asked them some questions about harm reduction strategies that they might be willing to use. A lot of people were interested in carrying naloxone, about 80%. People were interested in heroin maintenance and prescription opioid maintenance. And these are kind of hot button issues. So I'm not sure how likely it is that we'll have heroin maintenance or prescription opioid maintenance, but you know, people out there would prefer it. about half would do an opioid maintenance therapy like methadone or buprenorphine. And that kind of jives with what I found in other studies as well, that about half of people with OUD would be willing to go on an MOUD. That's a problem too, right? I mean, we need to figure out how to reach the other half. So the main takeaways here are that people with OUD don't necessarily prefer the fentanyl that they are being forced to use. They're discussing the risk of overdose deaths might actually reduce some of the risky behaviors in this population, and that there is a demand for harm reduction services, that people would be willing to use them if they were available. So buprenorphine precipitated withdrawal is, of course, a major issue right now in certain pockets of the country. I don't know how ubiquitous it is, but I know in Baltimore, this is a big issue. It's been a big issue at Johns Hopkins Hospital. It's been a struggle in our research studies. And there's, I think, probably two things that contribute to this. There could be more, I don't claim to know everything about buprenorphine precipitated withdrawal, but bup has a high affinity for the mu-opioid receptor. But it's also a partial agonist, right? So if you're somebody who's using fentanyl constantly, and as we showed earlier, that you might have even more downregulation of mu-opioid receptors than people who used heroin regularly or oxycodone regularly, and you're kicking the fentanyl off and you're replacing it with something much weaker. This causes a net deficit and can push people into a sudden withdrawal state. The other part that I think is related, and that what I believe we've at least provided some initial evidence of, is the protracted clearance of fentanyl. So the fact that fentanyl is likely being stored in adipocytes, being re-released into the system over time, makes it very challenging to know truly what somebody's fentanyl levels are when you start the buprenorphine induction. And there are some kind of telltale signs, right, of opioid withdrawal that I think we're all probably looking for before we start an induction, but still, it's just not as easy as it used to be. And there is, this is another study we did that I think provides some wider evidence of the problem with buprenorphine precipitated withdrawal. So here we were just trying to get a feel for what % of people across treatment centers might have experienced this. We did a survey study that we were able to push to 49 addiction treatment centers across the United States. Because all the data is de-identified when I get it, I don't have geographic information on where these treatment centers are, if they're in urban areas or even what part of the country they're in. So that's a limitation of this study. But we did ask people about their withdrawal symptoms after taking medications for OUD. That was the main purpose of the study. Everybody in the study was seeking addiction treatment. They took this survey at treatment intake. About 69% of the participants with OUD reported either probably or definitely using fentanyl prior to their opioid treatment episode. And we asked a series of questions. The last question that we asked, because we didn't want to prime anybody to what the survey was about, but the last question we asked was if they knew someone who had used fentanyl and experienced precipitated withdrawal after taking bup, and about 41.5% endorsed that. So here we just see the probability of experiencing severe withdrawal after taking an MOUD, given that you've taken fentanyl. So here we see a time effect for buprenorphine, that if it was taken within 28 or 48 hours since their last fentanyl use, that they had a higher probability of experiencing severe withdrawal. There was a higher probability overall of experiencing severe withdrawal with bup relative to methadone. There's likely this doesn't have to be precipitated withdrawal. It could be underdosed medication as well, but it's just much more likely to be endorsed by the bup population. And the timing with fentanyl, again, is kind of further evidence of precipitated withdrawal, and with case studies that we've now published on this topic. And this just shows the statistics for this study that the odds ratios were much higher within the first 48 hours. It's 5 times more likely if they took bup within 24 hours of their last fentanyl use, about 3.3 times more likely within 48 hours, and then the statistical significance falls off after that. I've observed it over 48 hours since the last fentanyl use, if you're just using the normal induction procedure, which we don't use anymore. So why is this such a big issue? Well, we're in the middle of an opioid crisis. This is like what, a 22-year opioid crisis at this point that keeps getting worse. And buprenorphine is, I would say, the most preferred and scalable medication for OUD. I don't personally have a preference for buprenorphine, but I think from a public health standpoint, it makes the most sense that that this is the kind of frontline treatment. We've spent substantial federal funds and our time and effort towards increasing the availability of buprenorphine. And I still think that's a good idea. So we just have to figure out a way consistently, and then make sense for clinicians that they can get people onto bupe. And I think hopefully this will be the majority of what we talk about after I'm done with the slides. It could be precipitated withdrawal, could be due in part to protracted clearance of fentanyl. It could also be due in part to reduced mu opioid receptor availability. I think that's an open question for the field to answer. It doesn't have, it could be in part, it could be one or the other. We don't really know. So there are different approaches to buprenorphine initiation and maintenance. The initiation side, there's a low dose approach, aka microdosing. This was originally designed to transition people from methadone to buprenorphine, but has been adopted for folks who use fentanyl. I think it works pretty well. I'd say the downside is that people have to spend, some time in a kind of moderate-ish withdrawal state, and that can be uncomfortable. One way to go around that is to use this full agonist plus a low dose approach. I think I'm going to term this the Thakrar approach, but I don't know. Somebody else might already have their name on this. I'm not sure, but basically here you're using a full agonist like hydromorphone to keep people from going into deeper into withdrawal, and then you're building up the buprenorphine in their system at the same time. And this appears to work pretty well. There's also a high dose or macro dosing approach where you're just giving a straight shot, like maybe 24 milligrams of bupe all at once. And the idea here is that you're just going to flood all available mu opioid receptors with buprenorphine, and that's going to prevent any precipitated withdrawal. I find this approach very interesting. I've never tried it. I don't want to try it until I see like a big study that shows that it works consistently, because I'm a little scared of precipitating withdrawal myself. Another option is to just have an opioid drought. So you just instruct people that on their own, they need to be abstinent from opioids. Wow, my PowerPoint just crashed. That's great. Well, that was like almost the end of my slides though, too. So maybe it's okay timing. Yeah, I can go the rest of the other slides. So the other, just the other parts that I wanted to mention were, it's not just about bupe, that we might require just higher dosing in general of buprenorphine for maintenance purposes, that folks who are chronically using fentanyl might require a higher dose. It's also true of methadone. And the OTPs that I interact with, I'll say that, since fentanyl has become ubiquitous, that they're using higher doses to maintain people. I think there's implications for the treatment of opioid withdrawal. So for people who don't want to be on a maintenance medication, the withdrawal treatment is going to be more challenging. Probably implications for naltrexone and extended release naltrexone when it's appropriate to start dosing those medications. And then the final thing I want to mention is that with any issue with OUD treatment, it's not like we have some actual continuity in the US on how we treat opioid use disorder. We have a very disjointed treatment infrastructure here that includes, from on one end of the spectrum, inpatient and residential, very high-end intensive care, to very low intensity care. And so you got to figure out what works in all these different scenarios. So it's not just the looking at how the medications work. I mean, that's probably the most important part, but then you actually have to look at the treatment settings as well. That has to be accounted for in the research on OUD. And with that, I'd like to thank you all for being here, and thank my collaborators. I had a nice list of them. There's a whole bunch of them, but thank you.
It's great. Thank you, Andrew. If you want to just stop sharing, then we can just have a nice question and answer discussion, and I will let others go first, but I have a bunch of questions. So if people want to just unmute for starters. If it gets hectic, we'll do hands up.
I guess I just have a comment to get us started. Thank you so much for this. My name is Joshi Aronowitz, and I work clinically in 2 different practices prescribing buprenorphine. And certainly I just want to, speaking to the importance of this discussion, I'm sure lots of us know this, but I'm just seeing, I was just texting Maggie about this actually, because it's something I'm like really concerned about. Like, we know that buprenorphine can be really great for lots of people, but I am starting to see totally anecdotally that at one of my practices where we almost everyone is using fentanyl, I feel like there's fewer and fewer new inductions that are successful and continue coming back. Like, I used to have a few new intakes, a week, and I expected that for some people it wouldn't work or they wouldn't make it back. And now every time I have a new induction, I'm like, oh, please, I hope this goes well and I see you again. And I even just like preempt the whole thing being like, this might be really hard. Like, let's just come back, even if it doesn't work, and we'll talk about it. But I'm just really concerned, especially about the most marginalized people who don't have access to like stable drug supplies, for whom this medication that can offer so much in some cases is like no longer a great choice for them, or like isn't working. So I don't really have a question. I'm just feeling like really concerned about this.
Yeah, since I'm not muted, I'll just say, I think that's a universal concern, and especially a big concern from NIDA and Andrew. And I think a lot of people are aware of that. It's just hard to understand the differences that people are experiencing, and then, side by side, people in big centers not seeing this challenge. So it sounds like Andrew and all of us have had more challenges, but we do see a lot of successes as well. I don't know if it's a combination of the setting and the marginalization, exacerbating, and the expectations around what's going to happen. It certainly seems to be a big component in Philadelphia. Rachel Horose had a comment or question.
Yeah, I actually have one quick comment and 2 specific questions. So my first comment is that it's so interesting. I actually have to go back and see if we've had less successful inductions. We still see so many that are successful, but we're very macro dosey in our practice. We really tend towards it. Although I have to say that the California and some of the data coming out with using 128 milligrams, we definitely don't do that yet. But I find that fascinating, going that high. I mean, to me, when I do 64, I'm already like, oh, I'm just really high. My 2 questions are, one, in all those studies, was there ever a quantification or an approximate quantification about what the average actual intake was? I know we use bags, et cetera, but certain geographic areas have micrograms per bag that they do, right? So if for New Jersey, DMI calculates, hey, they go in and they're like, oh, the average bag has anywhere between 1,000 and 10,000 mics, which as a physician sounds incredible. But like, I wonder if there's any kind of a study that's been done looking at that. So that's my first question. And then my second question is, I was looking at the naloxone stuff that you're putting out, which is fascinating to me, because one of the areas that we're working on is we reverse overdoses in the field, and then we give them buprenorphine in the field, right? Yeah. And we have had 0 precipitated withdrawals. Yeah. They've gone really well. So I'm trying to figure out, what is it that happens with the naloxone? Is it an affinity issue? Is like, what happens that allows the buprenorphine to bind? And I know for some of you that say, well, you're only on scene for 30 minutes. Like, is that really enough time? 50% of those do go to the ED, right? So 50% do get transported to the emergency department, where they stay for hours. and they also do not have precipitated withdrawal. So we've done 174 of those at this point.
That's so interesting to hear. We've talked about that in my research group, like maybe we could microdose naloxone, push the fentanyl off the receptor, and then rescue with bupe, and but we haven't done it. So it's interesting to see that you guys are doing it and it's working. I already forgot what the first question was.
So just the first question about the naloxone, if you have any idea of the pharmacology, but the second question was looking at the milligram, the microgram fentanyl in the bags and relating that to precipitated.
So we haven't done that. We've talked about doing it. Of course, challenges that it's hard to standardize what's in we call them pills here, which is weird, but they come in like little gel cap pills and they bust them open. I guess I don't have the drug seizure data to know exactly like what the average per unit is. But we have talked about just doing, like, we kind of figure the Baltimore opioid trade is fairly standardized probably across the city, right? Like it's probably, you're going to go buy a pill over here, a pill over there. What's in it might be different, but like the quantity is probably the same. I think it's like 0.1 milligram of whatever the heck is there. So we've started to look at some of that stuff. I mean, certainly some of the trends I've seen is like, yeah, people with heavier use have a harder time getting onto bupe. I think we've observed a gender difference, and especially like some of the worst precipitated withdrawal cases I've seen are in, women who are heavier set. And even though we've had them go without opioids for a while, those cases have really stood out to me that, so there might be some gender disparities here as well. And BMI would make sense with the lipophilicity of fentanyl. But again, I don't have enough data at this point to make any kind of concrete conclusions.
It's interesting. I get that sometimes when I present, people ask me about the BMIs of our patients and this whole idea that it's a fat saturation. I mean, it's quite paradoxical that patients inject more frequently because fentanyl lasts less long. And yet, withdrawal seems to take a few more hours to develop a really objective COWS of 13, so 24 or 48 or 72 hours. And yet, what is it that they're feeling at that point that they feel like they're having withdrawal? I don't know if Kyle wants to unmute and just talk about his experience trying to get people onto Vivitrol. So I could paraphrase that story, but I'd prefer if Kyle could do it.
Yeah, we've had a hell of a time trying to get people on. 8 days on an inpatient unit, no use, Narcan challenge, and they're sick as hell.
On day 6, right? Like
on day 8.
On day 8.
Right. So they get a full non-narcotic detox, pregabalin and lofexidine. And on day 8, and we've made 3 people really sick. The first guy we just gave 0.8 of naloxone to, and he just got tremendously sick, and we stopped doing that. Now we give 0.2 and wait and see. And even on 0.2, they've gotten significantly ill. So
I think Sandy Comer's group presented at a conference. I think it was CPDD, that they were quantifying levels of fentanyl in people who were in a withdrawal study with no other opioids, and they were still seeing like 50 nanograms per milliliter at 5 days. Like
yeah,
that.
Our guys at day 8 with 45 and 50 on the 2.
Yeah, that's pretty high.
That's fentanyl being measured in their urine. Is that what you're saying?
Yes.
Yeah.
On those days, yeah. I mean, interesting. So I wonder if you gave them the naloxone. I mean, so now they get sick. I guess you don't give them buprenorphine because your goal is ultimately to get them on Vivitrol.
Exactly.
But that might be the time to give them buprenorphine. Em, do you want to unmute and just share your comment? Because I think your experiences would be particularly unique. and put a comment in the chat that you guys could probably all read, but it says naloxone pre-induction, that it's a commonly known tactic among people who use drugs on the street in Kensington, that if they self-administer naloxone, I guess in some relatively low dose, that might be a strategy to tolerate buprenorphine. We did have some conversations with Mark Greenwald about this whole idea of clearing the receptor, much from, you know, Rachel's experiences, and whether or not that really explains. I mean, it's kind of two things, right? If you replace it with hydromorphone, like you're doing in your new studies, where, you know, getting rid of the fentanyl by just giving another full opioid agonist, or giving doses of naloxone to take away whatever that fentanyl effect is, and then giving buprenorphine. I know Rachel also had another anecdote that she published in a case report, or maybe Matt did, of a patient who was desperate to get onto Suboxone and asked for naloxone precipitated withdrawal as a gateway to buprenorphine.
Oh, yeah.
That actually worked.
So that it's interesting. I mean, it's kind of funny, right? Like the people out here on the street, they have to adapt much quicker than we do in academic medicine, right? Like I felt like with that that protracted renal clearance paper that I was like Operation Warp Speed. It took me, it's still from the time I had an idea to IRB approval, to run the study, to analyze data and publish, you know, I think it was a year, and that felt super fast to me. But in that year's time, people have to adapt if they're going to survive. So you do see, it is interesting to see as people come in, that they know about it now. When this first started happening to us, like a lot of people didn't know what was going on. Now I feel like when people come into our studies, like they know the risk of precipitated withdrawal. They know that if they take a really small amount of buprenorphine at a time, that it won't happen, and that they can build up their levels that way. So it's the word on the street, you know, unsurprisingly moves faster than academic medicine.
Yeah, that is probably to be expected. There are some questions, and especially in this crowd, about xylazine. I don't think when we spoke before, if you're seeing xylazine there. We're seeing it compounding a lot of patients who are hospitalized having withdrawal that seems to be adequately treated from an opioid standpoint, and then this other factor comes into play. I don't know if Sam or Eleanor want to comment on their inpatient experiences.
I don't know that it impacts the induction process, but I can say that lingering issues when we're getting people transition basically off of the fentanyl is that many people tell me it's the worst withdrawal that they're having, and it's sort of regardless of the PCA that they are on with benzodiazepines or burbs. And we had one lady in the ICU, and we had her on a dilaudid PCA with a phenobarb IV with Precedex, and she got up and walked out on that and said the xylazine withdrawal is too much. So we're not even doing, we're not attempting bup inductions on that. On a lot of these folks now, I discourage them and say, let's get you through all of this. And I'm so glad that you want to be on something, but why don't we hold off and let me replace it, you know, what you need right now with just a lot of agonists, and get you through the worst of it and get to that later. You know, I need you to stick this part out first before we get there. And like I said, this woman was more or less on 3 infusions and just up and walked out of an ICU because she said the withdrawal was too bad.
Thanks.
Yeah.
You're hearing that. Are you seeing that? Or I guess you're in a sort of slightly different setting, Andrew.
Yeah, I don't know as much about xylazine. We actually just talked about it in a study meeting today that we're going to start testing for it, but we haven't even been testing for it in my studies, so I don't know as much. The opioid agonist thing is funny though, because we, you know, have this protocol to maintain people on hydromorphone, and I keep having to up the dose, but I have to go back to the IRB every time and stuff, you know, so it's like a process. But at least like these folks can handle a pretty whopping dose of of hydromorphone. It does, like they're still in withdrawal. So, you know, so we're giving high doses, and it's like,
Yeah.
Like the amount that you'd have to go up to becomes very risky. I don't know.
Austin has a question. Based on what we know, do you think the risk of precipitated withdrawal is fundamentally a detection problem? Our current tools for measuring withdrawal are not effective for fentanyl, or more purely physiologic? Time or other opioid agonists are needed to eliminate fentanyl? Some of the stories and evidence seem to suggest either or both.
Yeah, it's a really good question. I tend to think it's more biological. And I think going by cow scores alone can be a little bit misleading sometimes because of the way that the items are weighted. And so somebody who's like very agitated, very anxious could have a higher cow score, even though their actual physical signs of withdrawal are fairly minimal. And that's a red flag, I think. For me personally, I want to see like physical withdrawal before I start the bupe. But maybe with the microdosing, it might mitigate that risk to some degree too.
Yeah, I think that's a great caveat that we try to share with novice bupe prescribers to look for more objective signs. Rachel Whiteman's asking, any insight into how much bupe can someone absorb sublingually at a time? If you're dosing up, does it make sense to give 32 milligrams 4 films at once versus 16 and 16? For example, if you're treating precipitated withdrawal.
It's a good question.
A lot of
I
filming.
think it's
Wow.
a physics issue. You can't fit more than 2,
Yeah.
right? I mean, the strips are this
Seriously.
big.
Oh.
I mean, when I put them in, exactly 2. I don't know where else you would put them.
Yeah.
That makes a lot of sense. Thanks. The other thing that I'm told often by colleagues is that like above 16, you're just saturated on all the receptors. And every time I've looked at all those studies, it's not fentanyl use that people are looking at the bupe saturation in the opioid receptors. And so I just didn't know if there was anything out there. I haven't found it in the literature that looks at what's happening at the mu-opioid receptor with people who are chronically on fentanyl with bupe.
Yeah, I don't think that information exists. I thought bupe saturation happened more at like 24, 32 milligrams. And that's why they made that the upper limit of dosing. But I could be wrong about that.
Yeah.
I think at 16 milligrams, it's about 85%
Okay.
saturated.
At 16 milligrams, you just said?
You're around 85% saturated.
Mhm.
That's what I've read in the literature too. And it's a bunch of different, it's looking at like compared to morphine, compared to hydromorphone and different doses, different routes. And so it's hard to say exactly.
Yeah, it does seem, I mean, back to Shoshi's experience, I do think that, and I wonder if our colleagues in Vancouver are going to be able to comment on this, because really we're creating what we did with alcohol withdrawal, in hospital systems in the 80s when, we'd have these people who would be drinking a lot, and then they would come in for these massive alcohol withdrawal hospitalizations, and then they'd survive, and then they'd go back out and they'd drink a lot. And what we called them were super, I don't know, super users. We had some other name, but essentially that we're creating these people who have, outrageous tolerance. And I've heard about some of these in toxicology as well, but I think that is part of the community that we're seeing are people who have just developed in very intense dependence and tolerance. So, maybe for the people in Vancouver who are getting safe supply, we really need to study what happens, what's the natural history of that, because that safe supply is also just going to escalate their tolerance, in a similar way. So it's just a little confusing to me, how much of this is just massive tolerance that we're seeing, and a drug that was used for a very different, opioid use disorder in the 90s that has really evolved a lot. I'm just going to try and take these last couple questions from Sam. I have difficulty with some patients never having elevated cows, and they seem to auto taper. I microdose or start methadone, but this baffles me and don't know what to make of it. 2, methadone clinics are still only once a day, but many patients find that inadequate and seem to metabolize it too quickly. I don't know what to do for them.
So I've seen the first question I've seen myself. I've seen it go both ways. I've seen people who just never have elevated cows like that. There's just a lot of, there's like variability in the experience of opioid withdrawal in general. Pretty wild variability actually. And then I've also seen it where they just don't go, and like it just takes a long time, like way longer than you think it should, for their withdrawal scores to start keeping up. And to me, this is indicative of some kind of reservoir of fentanyl or something in their system. The second one, yeah, I mean, yeah, people want to split the dose. So we're doing a trial right now. They just published the pilot study from it where they're doing it's like a take-home dispenser for methadone, and then you can actually split the dose, and they could then they don't have to come in every day. So we're hoping that works out. I'm hoping that like some of the pandemic era rules that relaxed methadone a little bit, I hope they keep it relaxed personally. I just think methadone is like a good treatment option right now for folks who use fentanyl.
Yeah, we agree. Just one last question, then we'll wrap up, from Rachel McFadden. The more we learn about precipitated withdrawal and the continuing evolution of fentanyl analogs, does it seem like we're talking ourselves into needing to meaningfully advocacy for safe supply alongside clinical troubleshooting, precipitated withdrawal, suggesting either or both?
That's that one.
I think she's saying in the interim, while we sort out the precipitated withdrawal, we should substitute safe supply.
Yeah. Yeah. Talk to your congressman about that one. This is going to be a battle, I think, to get that.
Yeah.
But I would be for, I mean, I don't know. I think like in places like in Baltimore, the drug trade here is scary. Like I would much prefer people have a safe way to go about doing things than what happens on the street here. I just think it's like we need a more humanist approach to how we're handling this.
Yeah, we agree. That doesn't seem to be the trends in our country in a lot of domains of healthcare and personal rights right now.
Yeah.
Yeah, so thank you so much. And thanks everyone for your participation. It's really a privilege to have an expert come and talk to us and bounce our questions and thoughts and sort of share all together. So I appreciate everyone's participation, and a special thanks to Andrew and Catherine for organizing, and hope we can continue to have these conversations as those unique experiences happen for all of us. So see you at the next one. Thanks again. And to everyone else. In 2 months, we have Mike Fingerhood from Hopkins. You might know him, talking because we're challenged by in-hospital use of substances, and he was going to talk about his policies and approach, another Ashish recommendation. So, all right.
Nice. That's great to be here. Thank you so much. It's an honor to be asked to speak with you folks. Appreciate it.
Our pleasure. Thanks again, Andrew. Thanks, everyone. Have a good day. Enjoy that beautiful afternoon.